Hey, welcome back, everybody, to the 2022 Big Give. We're excited today to have Dr. Liz Jalazo with us. Welcome, Jalazo. Will you introduce yourself?
Sure. Thank you for having me. I'm thrilled to be here today. I have wear many hats in this community and many other communities. So I always have to remind myself which hats I'm wearing. But I am the director of the Ladder Learning Network, our newly branded Ladder Learning Network. You might remember that previously was called the 15q Clinical Research Network. My day job is as a clinical geneticist, actually at the University of North Carolina at Chapel Hill. I may have seen some of you through our Angelman and Dup15 clinic at UNC. And I'm also a parent, a rare disease parent myself. So my 7-year-old daughter, Evelyn, has Angelman syndrome. And she's my middle kiddo. I have an older neurotypical daughter, Sloan, and a younger neurotypical son, Charlie. So I really live in this rare disease world, both professionally and personally. I'm thrilled to be here today to chat with you guys.
Thank you. I first of all love that you also have that experience as a parent. For those watching, sometimes I'll say, Liz, okay, parent hat versus
Yep.
your physician hat. So I love that about you. One of the many things we think. So one of the things we're going to talk about during our time together is ladder. Two pieces to this. People are confused. They're like, what's Ladder Learning Network? Do you mind giving a couple of seconds on why we even rebranded? I actually had a couple people ask me what was wrong with what it said before, but talk a little bit about that, and then we'll talk specifically about the Ladder database.
Great. Yeah, so why we rebranded? Good question. There was nothing wrong with the original name, the 15 Clinical Research Network, but I think it gave the impression that most of what we were focused on there was research. And while research is a really big, important component of what the Ladder Learning Network is, it really first and foremost serves as a network of clinic sites that are dedicated to providing excellent clinical care. We didn't want that to get lost. So the goal in developing this learning network of clinical sites was so that you as parents have somewhere to take your child where you are not the most expert person in the room. I know this firsthand from being a rare disease parent myself. It's frustrating always being the expert in your child's rare disorder. And sometimes it's really nice to walk into a room and be, among people who really get your child's rare disorder and really can provide excellent expert care. So, the first goal is that you're able to walk in and receive, one-stop shopping, multidisciplinary care, hopefully at a clinical site that's near to you, because we know that traveling with kiddos with special needs can be really, really challenging. So our initial goal was just to establish sites across the country and really ultimately across the world who have clinical expertise in 15q disorders, so Angelman syndrome and Dup15q. So that was the first goal, and that was a little bit lost in the title of 15q Clinical Research Network. So this first tier is really providing excellent clinical care. A second tier and a second really, kind of pillar of this network is to conduct clinical research. Clinical research can be everything from developing growth curves that are specific to Dup15, identifying best practices for everything from seizure management, management of GI issues, all of those sort of things. That all falls under the umbrella of clinical research. But so does clinical trial readiness and all the things that go into drug development. And so the Ladder Learning Network really serves as an important foundation for both clinical research as well as clinical trials and expediting drug development. And that's where the Ladder database kind of comes in, and where we start thinking about the importance of what the Ladder database does and the importance of collecting natural history data, which I know is what we're going to talk a lot about today.
Yeah. No, thank you so much. I think that's so important. And just for those who may be brand new parents who've been recently had their child diagnosed, I think it's so important too, just to remind people that when we have clinics, in case someone's watching this and isn't familiar with what the clinics are, it's important to understand that our clinics are not a freestanding urgent care building that you're going to walk in and go, oh, this is all they do. A lot of our clinics will see kids once a month, or maybe once a week. I think most of them are once a month. And I think that was a big important piece for our parents too. So thank you for that explanation of what we're trying to accomplish. So let's talk about ladder database. I should first quiz you on what the LADDER stands for. Do you know? Do you remember?
I do. I remember. I was very intimately involved.
I know you were.
Acronym. That was catchy. So LADDER stands for Linking Angelman and Dup15 Data for Expanded Research. And really, that's not what's most important about it. But again, we needed a catchy name, something that you could remember. But the purpose of LADDER is really to centralize data collection efforts for Dup15q and for Angelman syndrome. For those newly diagnosed families that are like, why in the world are we talking about Angelman syndrome and Dup15 in the same sentence, right? You know that Dup15 is caused by a duplication of that maternally inherited critical region on the long arm of chromosome 15. Angelman syndrome is caused by a deletion or missing that maternally inherited information on the long arm of chromosome 15. So while they're very distinct syndromes, and we certainly recognize that and appreciate it, the group of specialists that generally are providing that excellent care for a child with Dup15q is also the group of specialists that are needed to care for kiddos with Angelman syndrome and adults with Angelman syndrome, people across the lifespan with 15q disorders. And so it made sense to bring together those efforts. And as you mentioned, Carrie, most sites probably bring together that group of experts once a month and see a handful of kiddos with either Angelman or Dup15q syndrome. Some of our clinic sites separate them out into different days. And then other groups like the team up at Mass General have multiple days a week that they're seeing kids with 15q disorders and don't necessarily have one specific day that they're doing that. So it's different from site to site. You can go onto the website and see the subspecialists that are available at each of the clinic sites. All of the clinic sites should be able to handle any clinical issue that you might be experiencing or any concern that you might have. But it may not be done in the same structure at every different site. So some sites you may see a neurologist at that clinic day, you might see a handful of specialists, a neurologist, a geneticist, whatever the most pressing issues are. And then they may refer you to see, a GI doctor on a different day or something like that. But that should be your kind of centralized home for receiving medical care for the specific medical challenges that are most common in Dup15q.
Yeah. Thank you. That's such a good explanation. And to further expand on why we need the ladder database, because so many of our parents are like, I have no idea if I signed up, and we won't get into the logistics about technically signing up here. We'll certainly do that with our families, but why the heck would a family need to sign up for one more database? How is this any different than what they've done before?
Yeah, so I'll tell you, the idea for the ladder database was really born out of this huge burden that we know parents are asked to do, to fill out this, basically, these stacks of papers of, filling out your child's developmental history, their seizure history, all of the medical issues. We know that every time you go to see a medical specialist, you're being asked to fill out that same paperwork. And it's like, why can't this just all live in one central location where everybody can have access to it? That was the idea behind Ladder, was that you might have filled this out 10 times in the past, and I can't fix that, unfortunately. I have myself as well. But our hope is that you register for an appointment at one of the clinic sites, you get sent an electronic packet that has this information in it, and then it lives in the Ladder database forever. You don't have to fill out that same, detailing of all those developmental milestones ever again. You don't have to fill out, the detailing of all that early seizure history, every seizure medication tried, all of that sort of stuff lives in this centralized database where any clinician within the network can access that information. Yeah. So say you're being seen at one clinic, for clinical care, but you want to go to another, hopefully to participate in an exciting clinical trial. They still need all that same information, and they can now access it through the Ladder database. So that data lives in one centralized location. The other idea that we had was, particularly for this may resonate with families who have older children who may have participated in a research study at one clinical site, or multiple research studies. The idea is that through consenting to be able to share that data, you might have participated in a research study at an academic institution, and now that data can be linked to your child's clinical data from their clinical visit. And so it's not just all of that data living in separate locations where nobody else can access it. Yeah. You ultimately still get to decide who has access to your child's information and who doesn't, or whether you want to share or link that data for any other uses. But the goal was ultimately to reduce parent burden. Fill it out once, it lives in this centralized location, and then according to who you say can have access to it, then it can be accessed for other uses. Clinical care, research studies, and then ultimately for drug development. One huge purpose in collecting this natural history data is this is what drug developers need in order to be able to convince the FDA that they know what they're treating and that they can measure what they're treating, is by comparing their treatment to the natural history of the disorder.
Yeah, that sounds like that's so important for us as we're waiting and trying to get pharma to pay attention to us. And it would make sense that the more we can get data in there, the more they'll be able to say, okay, this is something we can work with.
Yep.
So that sounds really important.
Carrie, you and I do a lot of meeting with pharmaceutical companies, and one of the first things that, one of the first questions that they often ask is, what do we know about the natural history of the disorder? What natural history studies? Have there been funded natural history studies? Which Ladder basically is. And is that data accessible? Can we access that? Are we able to look at information like how many seizures a day is common in Dup15q, or what is the most common type of seizure that we might see? A question that we often get asked when we're meeting with pharmaceutical companies is questions like, what medications are patients typically on? Are they on a certain medication that might not work with the medication that they're developing? And so that's important information, but that all falls under that umbrella of natural history data. That's really, really critical for expediting drug development and expediting ultimately FDA approval of drug.
As a parent, what excites you that could come out of Ladder? Like just putting your parent hat on for a second.
Oh, so much. When Evelyn was little, she struggled so much with weight gain, and she was labeled failure to thrive. She had horrible reflux, and looking back, that was a lot of heartache in that first year or two of her life, when maybe that was normal growth for a kiddo with Angelman syndrome, right? And so being able, from a clinician standpoint, but also a parent standpoint, being able to say, actually, this is normal in this condition, and we don't need to panic about this. Or, no, this isn't normal even for this condition. This is when we need to be worried about this, right? So just being able to answer those basic questions when you have a child with a rare disorder of, what's normal in this disorder? What's normal for a child with Dup15q? What can I expect when if they don't have seizures by X age, what is the percentage of children who might go on to not ever have seizures, right? Those are important questions as parents that I know keep me up at night, and that I know they're keeping you up at night, and being able to reliably turn to data to be able to answer those questions really provides parents with a lot of important information, but also their clinicians with a lot of really helpful information to be able to know how to intervene.
That gave me chills for a second, because I was just on a call last week with a parent who said, I wish we knew what we know at least now, that if we could have tracked verbals and what a typical a Dup child may look like, because I wouldn't have panicked as much because my child was a little slower to start speaking or to use any verbal sounds. And gosh, it almost brings a little tears to my eyes thinking how important that would be just on an everyday basis to go, we're right on track. Like, this may not be the trajectory we were hoping for in life, but we're on track with what's the norm. And then we also know a little bit of what to expect. I know there's not a what to expect 101 with this.
Wouldn't we love that? A little,
yeah. Yeah, that'd be so easier.
Yeah.
Um,
yeah, no, I think that this is really, that's one of the most foundationally important things about natural history, is being able to compare what's going on with your child to what we expect for children with similar genotype, right? So that's the other big important question that we can answer is, we know that there's such variability in all genetic disorders. Angelman and Dup15q are not unique in that. And so being able to say, what do we know about children with an isodicentric 15 chromosome versus an interstitial duplication, right? Being able to answer those very specific questions, we can't do that without natural history data. So we have to collect the data, and then we have to mine the data. And this is one of those things that we wish would be an overnight. We could snap our fingers. And it's not. And, a lot of times it doesn't feel like it's the sexy thing or the most exciting thing, but it really, really, really is critically important, both for standardizing clinical care, which is incredibly important, but also for drug development.
What about parents that's huge. What about parents who have an older duper, which is our largest population right now? Should they look at this as, I'll do this as more of a help for the next generation, but is there any benefit to the older dupers that this could be good by putting things in latter?
Absolutely. I mean, I think it's critically important for us to be measuring natural history across the lifespan. There's absolutely no reason why we should only be thinking about this as a newly diagnosed or pediatric specific database. We know we have drug companies interested in treating this disorder across the lifespan. And so it's incredibly challenging for them to know exactly what they are targeting if we don't have natural history data to support. These are the issues that are most relevant in adulthood with Frederick syndrome, right? Or with Dup15q. So being able to explicitly say, these are the top 3 things that individuals and families are most concerned about in adulthood, and this is what we should be targeting. We can't do that without natural history data. And so this should absolutely be, we should be pushing just as hard to be collecting adult data as we are pediatric data.
Well, and it's interesting. We had just someone the other day say, is there anything about Dup15 in early menopause? And we were like, it'd be great to have that, to be able to show the next generation of what this could look like. But yeah, it's such a great point. We really do need it across all life cycles. So Liz, one thing too, is if we have more data, does that ever reduce the need for a placebo if you're doing a drug trial?
Yes, it absolutely can. So yes, in absence of a natural history, a natural history comparator is kind of the term. Then you can guarantee we're going to have a placebo arm. If the natural history is robust enough, there have been cases where the FDA has allowed drugs to make it to market approval without a placebo arm, because you were able to demonstrate robust enough change from the natural history of the disorder. So it should always be, that should always be, part of what we're striving for. I will say, I don't see us completely getting away from placebo arms of clinical trials. Right. But it's absolutely beneficial, to be able to have that argument.
Well, and I don't think, and I won't quote the number right now, but I think one thing that has impressed me being here was how often our data that we have currently that's being requested by pharma, by researchers. And I mean, that alone gets me like, okay, we've got to increase these numbers. Look how many people are interested.
Right. No, it's really true. The ladder database has been up and running. Gosh, I should know this. At least a year that we've been accepting data applications. And, just this month alone, I think we have reviewed 5 requests for data. And that's an important thing to discuss. So when you're consenting to include your child's data in the ladder database, you are consenting for it to be shared in a completely de-identified way. So no data is ever leaving the ladder database in an identifiable way. Nobody could ever say this was this specific child's data. On top of that, there are additional layers of protection. So anybody requesting data from the ladder database has to fill out an application form. That typically comes with an additional layer of requirement that at their institution or the entity that's requiring it has also applied for approval from a human subjects protection board or an IRB to be able to access this information. Again, even though it's completely de-identified and there's no way to trace this back to an individual person, there's still a lot of levels of protection to make sure that that data is being utilized appropriately and for a relevant purpose. And then there's a data access committee. And that data access committee has parent representation on it. So parents are approving whether this data is being utilized in an appropriate way and have the opportunity to ask questions of applicants and deny if we feel like the data request is not appropriate and say, no, this isn't an appropriate use of this data.
Yeah.
But there have been a huge number of requests recently, which is really exciting because that means people are thinking critically about how do we better treat this disorder? How do we think about new therapeutics? And, how do we expedite drug development? So it's really incredibly exciting and absolutely makes me reassured that this was a good use of our time and energy, because this is not, you don't stand up giant databases like this. This was a lot of blood, sweat, and tears that has gone into this.
Yeah, and it's definitely, like you said, not a fast process and not sexy because it's timely and it's something you have to spend time on. So
important.
What and not to get into too technical, but how often should parents update their data? Like obviously this is important if we want to keep tracking across the lifespan.
Yep. So the idea in the Dup15q community is that you would go on and register once whenever you decide you want to register your child with ladder or adult. You would fill out that big, you can take it in as many bite-sized chunks as you want to. You don't have to do it all in one fell swoop. You can, grab a glass of wine and do a couple of domains at a time. That's how I recommend it, at least. And then, so you'd kind of get that initial data, all that stuff input, and then think about updating it annually at their birthday. The way we have set it up is that you would likely consent to receive a push notification from the registry around a year around their birthday every year to remind you to go back in and update things like seizure frequency. Has seizure frequency dramatically changed? Has seizure medication changed? What major developmental milestones have we achieved each year? And kind of update it that frequently. There may also be additionally surveys that you might receive through the ladder database periodically. So if you consent to be approached about research studies, you can know about research studies that are available to you.
We get that question a lot. That's huge.
Yeah, it's huge. So that's one of the very first questions that you have to answer when you're registering is, do you consent to being approached about research? So if there's a research opportunity, or eventually clinical pharmaceutical companies could have the option to recruit patients through the ladder database. So you would consent to whether you want to be approached about a clinical trial even that way.
A good reminder, because we get that question. How will I find out? When do I know? Other than just checking like the clinicaltrials.gov page. And so that's fantastic. Good. And I know we're almost out of time, but so it sounds like from other advocacy groups, this really is key to getting notice from pharma companies for getting good therapeutics. We've got about 2,200 families that we work with right now. I mean, I would love to see everybody registered. Is there a goal number? Like, is there a percentage that we need to try to get to 75% or so that we can really make a difference in pharma's eyes for this, so we can get some gain?
Good question. So I like to think about this as lowering the barriers of entry, right? This is what we always talk about is how can we make it so easy for a pharmaceutical company? How can we just give them a layup, give them the slam dunk, right? Which, if you're sitting there thinking, what can I do to expedite drug development right now? This is it. This is the thing, right? Because a pharmaceutical company comes to us and says, how many patients worth of data are we able to access to be able to answer a question like seizure control, that kind of critical question, or behavioral things. I think a very I mean, obviously, I'd like to see everybody in the community enroll. But I think, even having numbers like 500 to 1,000 would be incredibly powerful for a pharmaceutical company who's thinking about trying to just get the baseline due diligence that they need in order to be able to determine whether this is an accessible or a patient population that might benefit from their therapeutic.
Yeah, that's fantastic. Well, is there anything you could think of I didn't ask you, Liz, that would be good for the parents to know? Did we cover it all?
I think probably one big question that families are asking is like, we've talked a lot about this giant burden. How long is this going to take me to fill out? I did the paperwork myself, and I think it took me about 30 minutes. So it's not like we're talking about hours and hours and hours and hours and hours,
Yeah.
right? We, we had parents review the intake forms and all the forms to make sure that the questions were straightforward, that they were understandable, that the format was user-friendly, that the bridging of the questions, you parents like I have done lots of these questions where you still have to, you think like, oh, if I answered no to that question, can't it just hop me to number 45 and so that I don't have to go through, number 17 through 45? Yeah. We've made sure that if you answer no to something, it bridges you to the appropriate place. So you don't have to then answer all of these inappropriate questions. And so there was a lot of attention put into reducing this parent burden. Again, we know it still is asking you to fill it out yet another time, but the hope is that we do this one last time. And then, that data, not only can we reduce future burden of you having to fill it out again, because if you show up at another place that has access to Ladder, they can just access all of that data and all that important information for clinical care, but you're also expediting drug development. We're, really contributing in other ways as well.
Yeah, I don't know why it came to my mind, but I was thinking, gosh, if you move across to a different state and you had to go to another clinic, how great that you would have it already in the system.
Yep, already there. Already there. And there are, as more and more pharmaceutical companies hopefully, get interested in starting clinical trials, it is going to happen that families are visiting more than one site. There might, we'd ultimately love for all research studies and all clinical trials to be offered at every site so that you didn't have to travel, but that's probably not realistic to expect. And so the reality of the world that we live in is that, to participate in a clinical study, one study might mean traveling to this site that's 3 or 4 hours away, and another might mean traveling much further. But to be able to then have all of that data accessible to any of those clinicians within the network for those baseline screening visits, for clinical care, for all of those different purposes, really should reduce that parent burden a lot.
Yeah, absolutely. Well, Dr. Jalazo, thank you. Thank you for spending some time with us. I know I'm encouraged to be like, okay, now we've got even more, get the word out. Like I knew all this and I'm still more encouraged. So thank you. Thank you for taking some time with us and all that you do for our families. And you're kind of the behind the curtain. Sometimes people don't always realize we're coming to you for lots of advice all the time. So thank you. Thank you for
always happy to do it.
Thank you. And we'll be back in a bit with our next, I don't think we call it the show. I don't think this is our traveling show yet. So our next presentation. So thank you, Dr. Jalazo.
Of course.